Today we're going to talk about maxillofacial prosthesis. So maxillofacial prosthesis is just the same as dental prosthesis, but replacement of more tissue, more structure, more functional. You know, when you make a denture, we replace teeth, the gum, supporting structure, making denture, and it will replace or restore aesthetic. You know, replace phonetics and replace function for natural teeth and supporting structure. For the maxillofacial, it can be teeth and associated structure. People lost their part of the palate because of a tumor or injury, and we can make denture, but the denture will be bigger on the palate that replace the missing part. And also can be restore the nasal structure at all of it or part of it. Can be restore the eye, could be just the eye lens, can be called ocular prosthesis, or the whole orbit, we can be orbital prosthesis, and can restore and restore the ear, part of the ear, the whole ear, can restore the mandible, can restore all these are maxillofacial prosthesis. Prosthesis in general is replacement of missing part of the body. And dental prosthesis, we're replacing teeth and associated structure. Maxillofacial it's more extension of our job. That's why I'm gonna talk about why the importance of dental replacement or jaw replacement as a part of the head and neck. All right, so this is the college picture. So why the jaws are very important? If you see the early organism, when they start, become they start eating, or they change from photosynthesis to get energy from other sources. They start to have mouth. So the mouth developed before eyes, before the brain. The mouth developed eventually before sometime even the nervous system. So simple nervous system, there's a mouth. So, and you can see there's a reptile. They have three, and the mandible have three bones, and with evolution from reptile to mammalian, some of these bones went back to the ear and become the malleus and ancus and part of the ear, the inner ear, and the mandible, or in old mammals they call it dentary, become just one bone. And the maxilla is also, it's just the base of a skull. So the evolution of jaws, it starts before evolution of ear, eyes, and even other part of the nervous system. And that's why the whole facial structure is to support mastication. Even they can see the zygoma here, and support the bite. The zygomatic arch to protect the TMJ, temporomandibular joint. All these structures to support the mastication and occlusion in general. In the facials, then after a while become the evolution of eyes, ears, and and other stuff. And I talked about by embryology. Maybe I can give you one lecture about long-term of embryology and how the process of when fertilized eggs start multiplication and become multiple cells, and these cells become flat, and then they migrate toward toward the first thing. Their outside cells will be ectoderm, and the inner side called endoderm, and their cells will go between them. They call them mesoderms, and they will grow and they multiply, and they multiply in different direction. And there was a book recently I was reading about electricity. All these who guide the cell to migrate toward this side. Why these processes? Like this is when the embryos start growing. These are mandibulomaxillary process. They grow together and they meet in the middle. And there is electrical process, there's electrical currents and electrical charge that guide them to meet in the middle. So that's why a new thing. When I was reading about old book, they said cause of cleft and palate is genetics, medication, environmental factor to the mother. This is all embryo inside the mother. So sometimes the mother will take certain medication can affect the growth of the child. And sometimes genetics, if they have certain genes, they have problem with the with the with the development of the child. So these processes, when they meet together, usually the process is covered by ectodermal tissue called epithelial tissue whenever, and they meet, the epithelial tissue should disappear and they meet together and diffuse. Sometimes the epithelial tissue stays there and they never meet. And sometimes in case of the cleft palate, the tongue will be inside the mouth. The tongue is too high. When the processes of the early palate, when they try to meet together, the tongue is going to be between them, and they will never let them to fuse. Can lead to cleft palate, and sometimes they cannot fuse together normally in the labial processes, can lead to cleft lip. Also, seen this book about the relation between facial muscles and the heart. That's very interesting. Maybe I'll send you the article about the relation between facial muscle and the heart. Even maybe one will give you a lecture about embryology. I'll talk about each process, each arch has its own blood supply, nerve supply, and how they grow together. If there's any disturbance in these processes or something wrong with it, we can lead to congenital defect. And one of the main congenital defect, we, as a prosthodontist or dental lab technician or dentist or maxillofacial prosthesis specialist, is a cleft lip and palate. It's very common, and it's very disfigurant for the early child. So, and it nearly need early treatment and early procedures to save the child or save the family, because the mother would be devastated also. When I was talking about early fish, early animals, they have mouth before they have eyes. Hagfish, they don't have eyes. They have like just light censoring disc, and they grow, and the mouth will grow, and so the mouth is the center growth of the face and the head and neck. We could discuss that with embryology. So let's talk about what's maxillofacial prosthesis. Maxillofacial prosthesis is artificial replacement of missing, damaged facial structure, primarily oral and craniofacial region. Craniofacial, crane is the whole thing of the brain and the skull, and the face area. So this patient has cleft palate. You can see the palate is open. I can see the nasal cavity from here. And some surgeon, they try to fix the lip first before the palate. When the patient born with a cleft lip and palate, the lip is not fused, and the palate. Why you think they do the lip before the palate? It's aesthetic first, but the other thing, when I seen when they do surgery on the palate, unfortunately, the center of growth of the maxilla is the median palatine suture. So any surgery there will damage the growth of maxilla. We've seen most of our patients, most of the denture, most of the cast, the maxilla will cover the mandible. The maxilla is bigger than mandible. It will overlap the like 2 millimeter, 3 millimeter, 2 to 4 millimeter overlapping the mandible. But when you do surgery to repair the cleft palate, it will, it will hamper or damage the growth. It will reduce the growth of the maxilla in general, and the scar tissue also will pull the the soft palate, you know, the uvula that close the oropharynx from the nasopharynx during speech, during when you eat or drink. All these scar tissue will make all these problems. Make a smaller maxilla, so a patient will be eventually class 3 because the mandible will grow normally, but it shows the mandible is bigger than the maxilla. Also, it will affect the speech because the uvula will be smaller than normal size. So there's certain voice that will become very strange. So there's always we can do a repair for this people. So we can do this is like a denture, extended denture to an obturator. At the same time, we obturate the opening between the oral cavity and nasal cavity. Also, maxillofacial prosthesis can be artificial eye, artificial face, can be artificial ear, artificial nose, and also they use different type of material. Silicone is the most common, but acrylic and some type of acrylic, soft acrylic can be used too. So all these can be categorized as a maxillofacial prosthesis. It's like they are a denture, but it's like bigger than denture. So there's a lot of history about maxillofacial prosthesis. In ancient time, there's no specialty. Like the people who make artificial fake eye, they can make artificial leg, I can make artificial thumbs. There's no specialty. They do all these things. So there's a they found this in Egypt. The patient has artificial eye in the socket, and in Sumeria and Babylonia, they go cedar. They go to Lebanon and they get cedar wood and they carve it and they make artificial fingers, artificial hands, and all these like ancient surgeon or ancient prosthodontists. They make all these things, even in China. But with time, the specialty become more, people who make teeth, they make artificial eyes, can they make artificial nose, and especially during the wartime, because the wartime they have more injuries, more tissue be damaged, so you can see more advanced in these things. The American Academy of Maxillofacial Prosthetics, founded in 1953. So another definition of it, it's a branch of prosthodontics. It's a prosthodontic concerned with restoration and replacement of stomatognathic. Stomatognathic. Gnathic is a jaw, stomato is mouth, and the craniofacial structure with the prosthesis that maybe can be fixed, or can be removable. And the art of the science of anatomy, function, cosmetic reconstruction by mean of living structure, sometimes non-living structure, because one of the prostheses we can make a skinograph. I could show you the skinograph. We can use it to expand the floor of the mouth. Also, the area of maxilla, mandible, face, or missing defective tissue because surgical intervention, trauma, pathology, or congenital malformation. So, why indication? Indication, first thing, why people need maxillofacial prosthesis. People with cleft lip and palate, they have congenital defects. Some individual born with facial deformity, cleft lip and palate, and can be addressed through use of maxillofacial prosthesis. I'll show you this. So this child has a cleft lip and palate. Both. Can you see this lip? This is his nose, and we can do this. It's made of acrylic, and the impression we can use a special tray, small tray. Even some dentists, they can use their finger with heavy body and take impression with their for the area, and you make a simple obturator, because this is very important stage of the life of the baby. If they can drink normally, they can drink milk normally. Even some there's some milk bottles. They have, especially for cleft lip and palate, they have obturator to obturate the opening between the oral cavity and the nasal cavity. And if the acrylic is too big, and there's no danger for the baby to swallow that, you don't have to be like, we can use artificial, like this is this is string to prevent the baby from swallowing that if it is small. But this is very vital, and you have to change it after a few weeks because the baby is still growing, and you have to change it until the baby will be. There's in a plastic surgery they have rule of 10. 10 months, 10 pounds, and HP 10. That's when they start doing surgery, and they do. Usually they do surgery of the lip first, then the palate in the future. So this baby has just palate, cleft palate. This patient has cleft lip and palate combination. So sometimes patients have cleft lip and cleft lip palate. And there's another thing with the cleft lip and palate. Sometimes they have congenital anodontia. Remember anodontia when they don't have no teeth at all? So when they don't have no teeth, the teeth is essential for growth of the alveolar bone. So when they don't have alveolar bone, they have just basilar bone, and there's going to be very complicated for us to make dentures in the future. So we need implant and all these. And also can be for maxillofacial prosthesis can be used for acquired defect, traumatic or surgical. Trauma. People can have trauma and can get cancer. So there is defect in the palate. You can see this is the nasal septum. Looks like this. This is the nasal septum, and the palate is being removed. So there is opening between the oral cavity and the nasal cavity. And you can take impression, and this is the impression or impression, and you can make like partial denture. It's the same as a partial denture. We set up the teeth, and we do the major connector, the minor connector, and the clasp. All of these we can do them, and it just has a more extension to cover the defect here. So just like partial denture, but it's more advanced partial denture. Also can be facial prosthesis, like when replacement of the ear, or replacement of the nose, facial scars, facial asymmetry. Really, I didn't see any facial asymmetry, because facial asymmetries can be treated as, maxillofacial surgery, but asymmetry can be done. Some people, they nowadays they use Botox, and silicone injection can be used as a you can adjust the facial asymmetry, but most of the time we do surgery because after scars or damage to the facial structure. Okay. Remember when I told you the soft palate can be damaged or can be scarred, and it will never function to replace as a sphincter between the oropharynx and the nasopharynx. So we can make partial denture. With the partial denture, we can extend our acrylic toward the soft palate and can help in function in the speech and mastication also. So this is just the frame before acrylic. Can you see it's a partial denture, but the frame without teeth. And then when this is with acrylic, we replace the teeth now, and we replace acrylic here to support the soft palate. So far, so good. I can stop if you have any question, but it's straightforward. It just we have a missing structure, not only teeth. We have missing structure like the roof of the mouth, and the procedure is almost the same. We take compression, and take compression. First, we have to. It's usually the treatment gonna be in combination. Should be surgeon, prosthodontist, dental lab technician, speech therapist, ENT. Sometime, especially when you work with the nose or the ear, ENT, ear, nose, throat surgeon, and all of them is a teamwork. You do the special X-ray, you do the cost, and you decide what you're gonna do. can make denture, or you can make extended denture, or whatever. So the procedure, patient evaluation, it's just like the denture. Patient evaluation, comprehensive assessment, patient history, condition, medical history, facial structure, and all these can be done. What the patient wants, they want phonetics, they want speech, they want aesthetic. All these important. So usually done by a team of medical or dental specialty. Can be so you do the treatment plan develop outline specific objective, what the prosthesis, and take impression, mold making. Most of the impression can be, if you remember, I showed you the video about the eye impression. They take impression to the eye with alginate, and so now they use more of the heavy body, light body, because it's available or less. It's more, although it's more expensive, but they have good marginal stability, and also it's a good impression. And you can make the denture, you can make adjustment, fitting, and sometimes some of the prostheses they need implant to be, like if you're missing the orbit, you can do implant around the orbit, and the denture or the prosthesis that's replacing the orbit can be fit on that implant. And so we could do fitting and adjustment, and as the same as the denture, we need follow-up, maintenance, regular maintenance, a follow-up visit, and we see the patient, how is the patient doing. So just like what we do with the denture. That's why maxillofacial prosthodontist or maxillofacial prosthesis specialist should be dental professional, because they know the procedure, they know the follow-up, they know how they do it. This is one of these books. They said the future of maxillofacial prosthesis as a future in dentistry in general. 3D printing is coming. The use of 3D technology enhance more accuracy and efficiency in prosthesis. And a biomaterial. Now they use biomaterial a lot. Like remember when we did the socket preservation, biocompatibility, all these things. Injection of material can be injection to inside the tissue to make the similarity or asymmetry in general. So you can do scan of the tissue, you can building mold cavity, and then you can do silicone. The silicone is one of the most common used for artificial eye or artificial ear and artificial nose, because this can be done and it can be flexible, and can you use the color matching with the patient's skin. All these can be added. These are just talking of why we need maxillofacial prosthesis. As like a denture, we need to restore as facial appearance. The first thing, aesthetic. Whether the patient are missing eye, missing ear, missing nose, they want to be normal. They want to look normal. So we have to replace the defected tissue, and we have to be by our maxillofacial prosthesis. So first thing, aesthetic. The other thing is it's a function or rehabilitation. Sometimes we do stuff for rehabilitation after surgery. So that's a function, like restore speech, mastication, swallowing, oral function, restore how they eat, how they talk. All these are why we do maxillofacial prosthesis. Also, when you restore the patient restore the patient, how they eat, how they talk, they become more comfortable. So you restore their mental stability and well-being. That's very important. Their patient will be more comfortable and more easy. So, but they need a lot of follow-up, because it's different from our denture, and especially when you replace a bridge for 3-unit bridge, differ from when you're replacing the whole maxilla. And they need a lot of follow-up. They need a lot of frequent X-ray. They need to see if our prostheses are sitting on teeth. These teeth need to be taken care of, because imagine our denture our partial denture is not only replacing teeth, we're replacing all the maxilla. And there is a lot of tension, a lot of movement. There is a lot of movement. The movement will damage the teeth that that support our denture of the clasp. So need a lot of follow-up. Okay, this is the point. It's a multidisciplinary team. Of course, they should not be just one person do the treatment plan. It should be maxillofacial surgeon, maxillofacial prosthodontic, speech therapist, psychologist, the ENT. Sometimes if it's on the eye, you need to talk with the eye surgeon or ophthalmologist, and you do the follow-up. This is another objective. So the objectives are the same. Aesthetic, phonetic, function. They are the same, all the same. We're not talking about why we need maxillofacial prosthesis in general. We have congenital, cleft lip and palate. Some people missing ears, some people, there's a cleft, facial cleft also. Acquired, can be accidental, surgery, pathology, and developmental, prognathism, retrognathism. I never seen prognathism, retrognathisms prosthesis because these can be treated by orthodontics and orthognathic, also orthognathic surgery. But this book at these things. So can be also the maxillofacial prosthesis can be classified intraoral, extraoral. Intraoral easiest for us because we know this, we know how to do compression because we know the teeth, but extraoral will be more difficult because we have not only occlusion, we have skin, and we have to choose the color of the skin. If there is the maxillofacial prosthesis replacing the maxilla and the nose, that's a lot of work because we can make the maxilla we can replace the teeth and the maxillary structure with acrylic and teeth, but the nose should be a different color material and should be flexible. We're not going to do acrylic and all these things. So the more extraoral is more complicated than intraoral prosthesis. Let me show you these defects. This is a tumor on the palate. You can see this is a mirror, so they put it to the patient so to show the maxilla. Look, this is tumor, and this is squamous cell carcinoma. So this one, when the surgeon you have to remove at least 2 centimeters around this. So going to be a lot of defect around this, and this is usually end up with the opening. We can see the nasal cavity. And also we're going to lose a lot of structure and we're going to lose the canine, most likely you're going to lose the canine and sometimes the lateral side. Because when it's a cancer surgery, you have to remove at least a peripheral normal tissue. So this is going to be a lot of, at least going to be intraoral. Another thing I just remember, maxillofacial prosthesis. If you treat a patient with cancer, they need follow-up because there's a cancer can be re-emerge in the area. So every now and then you have to see them, you have to remove the prosthesis and see the area, the sign of healing, the sign of damage, sign of recurrence of the tumor. These are very important for us. That's why we have to follow up with the maxillofacial surgeon and prosthodontist. This is a cleft lip and palate for baby. Cleft lip and palate. This is just palate. So this is congenital defect. This is prognathism, retrognathism. But I would treat it with surgery. There's surgery, it can easily be treated by surgery and sometime with orthodontics. This case can be treated with orthodontics. Especially they are young, we're making the growth of the maxilla, there's a special appliance, we can stimulate the growth of maxilla. Anyway, that's one of the treatments of retrognathism and prognathism by prosthesis. Okay, so the another classification: intraoral, extraoral, combination, radiotherapy prosthesis. Let me talk about radiotherapy prosthesis. People with cancer, one of the treatment of cancer is radiation. Radiation is radiotherapy, is high energy beam, usually targeting cell that multiply fast, which is mostly cancer cells. But when you do radiotherapy, you want to damage just the cancer cell. You're not going to damage. You don't want to damage the other adjacent structure, normal tissue. So imagine patient has a tumor on the cheek, and the treatment cannot be used by surgery. You have to do radiotherapy. So you can take compression of the area, and you make a prosthesis made of lead, and the lead will cover the normal tissue, and the opening is just over the cancer tissue or the tissue targeted by radiation. And that's called radiotherapy prosthesis. It can be used, I think, in people with breast cancer. They can use that to protect the adjacent structure, and the radiotherapy radiation energy will be focused on the target area only. That's a radiotherapy prosthesis. So it can be the same. You can take compression to the area, but the material that made of radiotherapy prosthesis should absorb radiation, should be X-ray radiation, can be lead or other metals, or sometimes acrylic reinforced with metal. Okay, so maxillofacial prosthesis can be obturator. Obturator is the closed oral cavity for the nasal cavity. Feeding aid prosthesis, just like the baby with the cleft palate. Speech aid prosthesis that we can replace the uvula. Palatal treatment prosthesis can be sometime when you do surgery to the palate. I told you it's the palate. The growth of the palate starts from the midline, the center of the growth of the palate at the midline. Sometimes we can make a palatal expansion prosthesis that can expand the palate. Salivary stimulate prosthesis. This is over because we can we can give the patient artificial saliva. Palatal lift prosthesis, nasal lift prosthesis. There is nasal lift prosthesis. There is other palatal surgery. We can do prosthesis. Some of these things we never use. I never heard about them, but they exist in the book. Mandibulectomy prosthesis. Usually when you have a tumor in the mandible, you have resect the mandible, you need to replace it. So it can be made of titanium, can be made of special 3D printed material, and all these things. Intraoral fixation prosthesis. Stent prosthesis. Stent prosthesis, can we use it for our implant? So we can use a stent prosthesis. Stent is like a guideline for us to. Tank prosthesis, I seen it in the book. I never seen it in real life. Tank prosthesis. Extra upper facial prosthesis, mid facial prosthesis, hemifacial prosthesis, nasal prosthesis, orbital prosthesis, auricular prosthesis. Yeah, but there is a difference between orbital and ocular. There is orbital, you replace the whole orbit. Ocular, you just replace the eyelids. Combination, usually when you have a tumor or injury, there's not going to be just one tissue will be damaged. Always you have tissue inside and outside. So radiotherapy prosthesis, I talk about them. So this patient, most likely he's had a cleft palate prosthesis. And you can see this fascia denture. I'm replacing this area. And this is feeding a prosthesis. This patient have cleft palate, and we can make acrylic and we're feeding prosthesis. This is uvula prosthesis, speech aid prosthesis. That's like a partial denture, but there is extended to see the uvula. this is for occlusion. Sometimes we adjust the occlusion and we can, should be part of the prosthodontic in general. Okay, this is more classification of intraoral prosthesis with times. Okay. We have meeting at 10 o'clock and I have to leave. So maybe I will finish that late next week. Okay, guys.